Morning or good afternoon, ladies and gentlemen. Welcome to the MediGain ICD-10 Planning Essentials for Medical Practices webinar conducted by our Chief Medical Officer, Dr. Eric Beyer. He's also an MBA. Today's webinar will be recorded, and you will be getting a link to that later on this afternoon. And all the slides that you see, you will be getting a copy of those too. I'll be sending you a link to where you can go to our website and you can see the video and you can download all the slides. So without further ado, I'd like to introduce you to MediGain's Chief Medical Officer, Dr. Beyer.
Thank you, Clint. So to start, just brief introductions on all of us from MediGain who are on this call. You've just met Clint, who's our Vice President of Marketing. Also on the call, in addition to me, is Carl Johnson, who's our Vice President of Western Operations. He'll help with any questions at the end regarding client or operational issues. And also Liz Jones, who's a certified professional coder. She's our coding manager and also our internal ICD-10 coding resource. So Clint, if you can go to the next slide. The overview today, really there's two overriding goals. The first is to motivate people that perhaps have procrastinated until now to start anything regarding ICD-10. So now is really the time when you can't procrastinate any longer. I saw a figure last week that over 50% of physician practices have not done a transition plan for ICD-10. So now is the time to start if you fall into that category. And what we'd like to do today is really present you with an overview of a transition plan to do that. There are more detailed transition plans out there from payers like CMS, as well as electronic medical record vendors and so forth. But we really tried to take a approach of what are the key priorities you need to focus on now. And if you're already doing it, that's great. You can use this as a checkoff sheet to make sure that you don't have any gaps or holes. But we're going to provide a brief overview of ICD-10 versus ICD-9, look at some of the risks and key impacts, and then walk through a transition plan that we would recommend groups start on if you've not done that already. I will tell you that we've tried to provide a good level of detail in the slides so you can use those for a reference. So I'm really going to be providing just an overview of the key points on each slide and try to leave adequate time at the end for any questions. So if we could have the next slide, please. So to start with, for those of you who may not have heard, October 1st is the actual date of implementation and compliance that's required for ICD-10. Now there's really two components to ICD-10. The first is ICD-10 CM, which replaces the ICD-9 diagnosis codes. So that's what we're going to be focusing on in the webinar today. MediGain does not do any ICD-10 PCS billing, and that's for the hospital side. So those are for inpatient hospital procedures. If you do provide inpatient hospital procedures, we advise that you would work with your hospital, and they should have resources as well as education available to you to help work through the issues there. It's important to note that this does not impact CPT or the HCPCS codes that you may be using currently. So for all of your services, those CPT codes don't change, or the HCPCS codes for medications, durable medical equipment, any of the modifiers and so forth. Those all remain the same, so we're only talking about diagnosis codes. Next slide. One of the key issues with ICD-10 that's really driving it is increased specificity. So the whole goal is to get more granular in detail on the diagnosis codes, identifying manifestations of conditions, causes of injuries, different things like that. So there's been a large increase in the number of codes. We're going from roughly 14,400 to around 69,400 diagnosis codes on the ICD-10 CM side. And then on the procedure side, it's going from about 4,000 to 72,000 codes. Next slide. The impact of the ICD-10 transition really is going to depend on the practice, depending on your specialty, the size of your practice, the type of practice, so if you have different revenue centers. And what you want to do is really focus in on what are the key risks and the key changes as they apply to your practice and your specialty. There are some codes that directly crosswalk from ICD-9 to an ICD-10 code. However, it's only roughly about 25% of the codes. Most of the codes do not directly crosswalk. The biggest change and the biggest specialty impact is going to be orthopedics and musculoskeletal care. They comprise around 50% of the new ICD-10 codes, and it's because there's a lot more detail on things like laterality, so right or left. That alone accounts for about 40% of codes. Now on any injury, it requires an episode of care. Is this the initial visit or the subsequent encounter? and if it's a late manifestation or a late sequelae of an injury. Much deeper anatomical detail and getting into things such as severity. Next slide. So as I mentioned, really orthopedic surgery is going to see the greatest impact from this, but other specialties will be significantly impacted as well. Family medicine and internal medicine, because they provide such a broad array of services, will have a significant impact. Pediatrics will be impacted, OBGYN. Now things are going to be linked much more closely to the trimester, as well as cardiology and even urology are going to be experiencing significant changes in some of the codes. So you can see a breakout of some of the particular clinical areas, how like from fractures we're going from a little over 740 codes to almost 17,100 codes. So a big change there, and so again you really need to apply what of these key changes crosswalks over to your specialty and what do you need to be careful about. And I should note that we're having two webinars again tomorrow. Tomorrow we'll be focusing much more on the ICD-10 coding and documentation requirements themselves. Right now in this webinar we're focused more on the transition plan, so we're only going to provide a high-level overview. Next slide. So these are some of the key changes within ICD-10 that are differences from ICD-9. So what you should do is go down through this list, and if you're seeing a lot of diabetics or you see a lot of injuries, if you see a number of patients that might have stroke or your cardiology practice, acute myocardial infarction, oncology practice, these are some of the key things that are going to be changing, so you're going to want to be aware of those and really focus in on those changes in ICD-10 as part of your education efforts. Next slide. Again, looking at some of the changes, so as an example, we're going from roughly, or from actually 16 fracture codes in ICD-9 for a femur fracture. That expands all the way to 1,530 codes for femur fracture in ICD-10. So obviously, if you're an orthopedic practice, you not only need to be able to get to the complete and appropriate ICD-10 code, but you want to be able to do that in an efficient and time-effective manner. So being able to work with your electronic medical record, or if you're using hard copy systems, make sure that you have plenty of prompts and cheat sheets that allow you to quickly and effectively get the appropriate code. Diabetes is changing, so now we have to designate what's the type of diabetes, type 1 or type 2. Is it due to an underlying cause, such as gestational diabetes? We're looking at the degree of control. And there's also a connection with what are the complications. Does the patient have polyneuropathy, or do they have peripheral vascular disease or ophthalmic complications? All of those components now are going to need to be linked into the diabetes code. Injuries changes significantly. As I mentioned, you now need to include what is the encounter type. Is it an initial, subsequent, or sequelae? So if you do not have that in there, then that would not be a correct code, and so we would expect the payer would deny that code and send it back if you did not designate if it's initial, subsequent, or sequelae. A new concept in ICD-10 is underdosing. So now ICD-10 wants to identify what's the cause. If a patient has not been taking their medication as prescribed by the physician, is it due to financial hardship? Is it due to an age factor where the patient has a debility related to age, or other causes, so that they can start doing data mining and linking back from a health population management standpoint. If patients aren't taking their medications, why is that, and what preventive measures can be put into place? Next slide. So the code structure of ICD-10, we're moving from 3 to 5 digits under ICD-9 to now we have 3 to 7 digits on ICD-10. Also, ICD-9 was primarily numeric, so we did have our V codes and our E codes, but the rest was numeric, so it was easier to look them up. Now with an alphabetic and numeric mixed in the different digits, it makes it much more difficult to look up codes in a manual versus you need some type of an electronic mechanism to do that. I should point out not all codes will have all 7 digits, so some of them may be shorter depending on the type of code. However, if 7 digits are required, so for example, if you do need to give the encounter type, you need to code out to the full number of characters required, or else it will be denied. The other important point is, although ICD-10 is really focusing on trying to become more specific and detailed in our diagnosis codes, it does allow for some unspecified codes. However, not nearly to the same degree as ICD-9 does. So for some specialties, 30, 40, 50%, or even above that could be unspecified codes that you were able to get away with under ICD-9. Under ICD-10, it's more than likely that payers are going to scrutinize that much more closely, and they're going to be wanting the specific code rather than giving an unspecified code. So you really need to try to make sure you're giving the most complete and accurate code, and if there's a specific code that's appropriate for that patient account, if you have all the information to provide that, you want to provide that code rather than the unspecified code. Next slide. So this is the actual code structure for ICD-10. So as an example, you can see M84 is a disorder of continuity of bone. And I should note on our presentation tomorrow, we'll be going over the entire table of contents for ICD-10, so you'll see the breakout of all these different code categories. The next 3 digits in yellow covers the etiology, anatomic site, and severity, but that's only if applicable, so not all diagnoses will necessarily require those digits. And then finally in green is the extension, so that's where something such as the initial versus subsequent encounter would be. So as our example, M84.311A, this is a stress fracture of the right shoulder initial encounter. So you can see how these building blocks add together to come up with what our final specific code is. Next slide. So these are the key risks. So really these are the top 5 risks that you need to pay attention to from a practice standpoint in how you address the transition to ICD-10. And we'll go through more detail in these as we touch on the impacts of ICD-10. So financial risk, the key concern there is fewer payments, higher costs during the transition, making sure that providers have appropriate education and that they're proficient in using the ICD-10 codes if they're doing the coding. At the very least, making sure that they're proficient in documenting so a complete clinical service so that it meets the requirements that a coder can assign the appropriate ICD-10 code. Payer readiness and various vendors on their software systems and the issues that they have to go through. Just as ICD-10 is a challenge for hospitals and physician practices, it's also a significant challenge for payers. The problem is if a payer has a problem, it'll backflow to the physician and that it will delay and perhaps result in the denial of payment. So that's where you really will want to check on how are your payers prepared and get some specific communications and questions with them to make sure you understand if there's policy changes and so forth, what do you need to be prepared for. Staff readiness and process readiness, anything that's touched by an ICD-9 diagnosis code, you need to put that in your inventory, whether it's a form, a process, or whatever, and look at it to see do you need to update it or change it for ICD-10. Next slide. So the key impacts, like I mentioned, we'll go through each of these, starting with the financial planning and budgeting, but this is really a checklist of the key things you want to look at, tie into those risks, and say, what is my plan to address this or to try to mitigate the risk? Next slide. So starting with the financial planning, there's a potential for a decreased revenue, and really it's a large result of really 2 components. The first concern is slower charge entry. Because there's going to be more detail required at the diagnosis, if the physician does not provide that detail either in their documentation such that a coder can code the appropriate ICD-10 code, it will likely come back to the physician to provide that additional clarification or documentation. Or if we send it through to a payer, so if the physician's doing their own coding, MediGain's not coding it, we'll send it on through, and if the payer denies it, it'll come back again. So we have the whole issue of denials as well as making sure that those charges get out in a timely manner so that if there's any updates or clarifications that are required, that those are done timely. Payer claims adjudication processes. Some payers have upwards of 100 different electronic interfaces with clearinghouses, other payers, and so forth. So any problems or hiccups in their electronic interfaces or in their software, again, will flow back to the physicians with delayed or denied payment. And then we also have to worry about how are the payers doing on their staff productivity issues, on their processes, and all the things that they need to do to accommodate ICD-10. So the end result is anything that causes a payment problem, ultimately it's the physician group that has that lack of payment or lack of revenue while that problem or issue gets resolved. Similarly, there's a risk of increased costs. So we expect there's going to be decreased productivity of both staff and providers. That may require overtime. It may require additional providers. Training software, there might be external costs. You might have to do hardware upgrades. But you really need to develop a budget and plan around how do you address the contingencies for the financial decreased revenue as well as increased costs that may result from the ICD-10 transition. Next slide. Front desk will also be impacted by ICD-10. So if your practice uses a new patient form or any type of a patient intake form that's related to eligibility of insurance or documenting the patient's history. Those are going to need to be updated to make sure they accommodate ICD-10. So for example, a new patient form, you'll want to make sure that there's check boxes or information boxes on there for documenting what you need from an injury in order for the physician to be able to ask the right questions and get the right information for the appropriate ICD-10 code. Any changes in insurance eligibility or coverage related to the ICD-10 diagnoses that are now more detailed, that will need to be accommodated by the front desk. Scheduling changes, so practice management and electronic medical record softwares are going to be upgraded. Those changes may flow through to the way the front desk schedules patients. Superbill changes, we'll talk about that in a minute. Superbills may no longer be something that will work for your practice based on the level of detail for ICD-10 diagnosis. Depending on your specialty, a multi-page superbill may not be realistic for your practice. The other key thing you need to keep in mind is patient inquiries. So patients are not going to be educated on ICD-10. So if a patient gets a denial or they're not pre-authorized for a service, they may be calling the front desk or they may be asking the front desk questions at the time of service, and your front desk is going to need to accommodate that. You may even want to have a handout that you give patients related to ICD-10. Starting October 1, we're going through this transition to ICD-10. Please be aware of that might cause some slowdowns in some of our processes, or make sure you have this information. But think about what your patients are going to need to know and what you need to get from them in order to accommodate ICD-10. Next slide. Decreased productivity, so the first and foremost is the increased documentation that's required. So it's not only at the time of the services rendered when that additional time is going to be required of the provider, but also if there's additional querying that needs. So the provider did not give that seventh digit for an injury code, did not give the encounter type, and it needs to come back to him or her, or we need to provide an additional digit for the manifestation of a diabetes code. So your processes are going to need to accommodate that, and you're going to need to plan on some decreased productivity. One study suggests that for ICD-10, providers will see a permanent decrease of up to 3 to 4% in their productivity. So will that require more providers if you're a larger practice, or will it require some changes in the way that you schedule patients? But you need to be aware of these and watch out for bottlenecks and be prepared to accommodate these bottlenecks due to the decreased productivity. Next slide. There's also going to be additional workload as part of the transition, and so that's going to have some cost impacts as well as productivity. So obviously for the physicians, it's the additional coding and documentation work. But also clinical staff, nurses, medical assistants. Orders will need to accommodate ICD-10. They may need to do additional clinical documentation if they're documenting an electronic medical record or otherwise. Advanced beneficiary notices will need to accommodate changes for ICD-10, and especially any payer pre-authorization requirements. What are the triggers for pre-authorizations? Will those change as a result of ICD-10? So you're going to want to have good communication with your payers in order to identify those and then design those into processes and forms in the practice. Labs can also change, so you may be getting more lab inquiries. If you're sending a patient out for labs, the lab's going to want a billable diagnosis, so they may be calling back to the practice, or they may be asking for clarifying information or documentation to support a billable diagnosis so that the service can actually be, the lab can be paid for. Billing, for most of our clients, MediGain is doing this, but if you're doing any of the coding work within your practice, so you have your own coder, then you need to make sure that your coder is trained in ICD-10, and ideally they're certified in ICD-10 either by American Academy of Professional Coders or the American Health Information Management Association. Also, the billing workflow back and forth to MediGain, we want to make sure that all of those systems and processes are good and we can accommodate work coming back if it needs clarification and how we get that timely resolved. Changes to privacy policies, any payer coverage policies that we mentioned before, those all need to be accommodated. That's going to be some additional work for front desk staff and potentially other administrative staff. The practice administrator or office manager is going to have more work, developing a financial and a training plan, making sure the operational processes are updated, reviewing payer contracts and policies, what are the key risks, what are the key changes, what do we need to confirm and contact our payers about. And as I mentioned for coders, they're really going to need a much higher level of knowledge directly related to ICD-10 than they've had before, so they're going to need a significant amount of additional training as well as practice with ICD-10. Next slide. Claim submission, so as I mentioned, the charge lag time. The two key issues here are, one, the charge getting out, and can you put in processes at the time of service or at the end of the day before those charges are sent to MediGain to ensure that complete and accurate ICD-10 codes are provided by the physician if the physician is doing the coding, or that there's complete clinical information if the physician is not doing the coding but MediGain is doing it. Because you want to prevent us from having to send it back to you, because we can't, our coders cannot assign the appropriate code if the complete clinical information is not there, so we'll have to send that back. And so that's where you're going to need to have a good process to monitor those held claims or those return claims. You might want to do something as simple as if you're doing a manual process so you don't have electronic medical records, maybe all of the charts for each physician is put in a table in the administrative area so that you can see visually how many charges are stacking up for each provider to make sure you stay on those providers to get those taken care of in a timely manner. If it's done through an electronic medical record and there's a queue of unbilled services waiting for updates or waiting for clarification from the physician, somebody needs to be checking those for each provider to make sure that there's not one or two or more providers that are having big log jams building up of these unbillable services that are waiting for finalization in the electronic medical record. Next slide. Payer denials are expected to increase. CMS says up to 200%. And that's a result of a number of different things. So first we have new or revised claims edits. Most payers have in the neighborhood of 70 to 80,000 claims edits. So those are different edits that the claim must pass through in order to be paid. How will those claims edits all accommodate ICD-10? Or will they result in rejections? What new edits will payers be able to add? Because now we have much more granular data through our diagnosis. They might pay for one thing but not pay for something else now that it's more detailed. Are they going to have more medical necessity denials as they tighten up their policies, so local carrier determinations from Medicare or other medical policies? You want to make sure that you stay tight on following your payer communications, any newsletters that they send, any updates or letters on contracts and so forth. Make sure you identify what are some of those key changes, and make sure as well you communicate those to MediGain, to your client services manager. As I mentioned previously, any prior authorization or referral requirements. I would call up your key payers and explicitly ask them, are there any pre-authorization changes related to our specialty or any new referral requirements or anything that we need to accommodate in our forms or in our process for pre-authorization and referrals. And then finally, timely filing. So if your payer has a tight timely filing deadline, will they accommodate or be more lenient on that through the ICD-10 transition, because it is going to have result in more delayed filing, and you don't want to lose payment because you've pushed beyond a 60 or a 90 or even 120-day timely filing requirement. So get clarification on those and see if you can get the payer to extend that out. Next slide. Some other reasons, so we've got ICD-9 crosswalk issues. So as an example, if a patient is in the process of a service, say you're an oncology practice and you give them chemotherapy in September and then you give them another round of chemotherapy for the same problem in October. Two different coding systems, ICD-9 in September, ICD-10 in October. How will the payer deal with that, or will that result in a denied claim? Payers, I need to make sure with all of their trading partners. Some of them have more than 100 different electronic interfaces, as I mentioned. So you want to make sure that if they have any issues there, that we're able to identify those denials and resolve those. As I mentioned previously, any of the issues that they would have in productivity, processes, software glitches, any of those things can result in denials or delayed payments for physicians. So we want to make sure we're monitoring those carefully. And then finally, keep in mind that work comp claims will not change to ICD-10. So if you're an orthopedic practice or another type of practice that sees a significant number of workers' compensation claims, those will still be filed with ICD-9. So you'll need to be able to accommodate both ICD-9 and ICD-10, as will the payer. Next slide.
You're breaking up a little bit there, Eric.
Can you hear me okay?
You're breaking up a little bit.
Can you hear me now, Clint? Are you hearing me any better?
Yes.
Okay.
I can hear you now. Good.
Okay, good. Sorry about that. So superbills. So superbills may not be practical for some practices. So what I would recommend is, if you're using a paper superbill currently, the first thing I would recommend is go to the American Academy of Professional Coders, AAPC website, and it's listed in our resources slide at the end of this presentation. Obtain the top 50 ICD-9 codes that are translated to ICD-10 for your specialty, and then compare that to your superbill and look at it for an updated superbill. Similarly, take your top 20 ICD-9 codes, crosswalk those over to ICD-10, and combine the two and see, can you make a one-page list of diagnosis codes so that you can still keep your Superbill to one page, maybe front and back? And if not, if there's codes that exceed that, can you put that on a laminated card, or perhaps you even want to turn the AAPC top 50 into a laminated card that you or the providers can use for reference? Also on your Superbill, I would recommend that you leave some space so that the physician can write in if there's some additional documentation. If they want to, if the exact code is not there, but they can provide severity or some other type of information that would help in the coding, that may be appropriate. If you can't accommodate a paper Superbill, look at either a charge push through your electronic medical record, or is there an electronic Superbill? But you're going to need to figure out a solution to either updating the Superbill or changing over to an electronic form of providing that charge and all the other information that's on a Superbill to MediGain. So again, make sure any form or any workflow that's touched by ICD-9, you pull those out, you flag those, and you look at, does a change need to be made to accommodate ICD-10? Next slide. Electronic medical record templates are also something that could be significantly impacted. So depending on the electronic medical record that you're using and the vendor, first of all, make sure that your electronic medical record and your practice management software are updated. So MediGain is updating all the systems that we host. However, if you have your own service on site at your practice, you need to make sure you contact your practice management and or electronic medical record vendor that they update your server with the most current version of their software to accommodate ICD-10, as well as making sure that they have the ICD-10 diagnosis dictionary in there. You also need to look at any electronic medical record templates. Do those need to be updated, or do the prompts need to be changed to accommodate ICD-10? And also, what about the functionality? Different vendors are doing different things in terms of the functionality to try to help physicians select the most appropriate ICD-10 code in the most timely manner. So you want to make sure that your clinicians are trained in how to use that functionality so that they can be productive and be as time efficient as they can in selecting ICD-10 codes. Next slide, please. So these are the three types of training. We'll go into a little bit more in a minute, but staff need ICD-10 awareness training. Providers will need the next level of training in addition so that they can code and document proficiently with ICD-10. And then coders will need the most in-depth training because they really need to be at a much higher level and appropriate use and selection of ICD-10 codes. Next slide. So this is the 10-point transition plan that we recommend. So we'll go through each of these and talk about it a little more in detail, but this is the checkoff list that I would recommend to make sure that each of these points is covered as part of your transition plan between now and October 1st, as well as following October 1st, because you need to make sure you're doing post-transition monitoring and feedback. Next slide. So where it starts with is leadership. So the practice administrator or office manager, whoever is the administrative leader in the practice, really needs to be the key person driving the operational planning, making sure that there's a financial plan and you budget for ICD-10, you have contingency planning in place, as well as making sure there's accountability from the staff on what needs to get done, what's the timeline it needs to get done, what are the workflows, forms need to be changed. But in a sense, create that master list of work that needs to be accomplished, tasks and activities, and then make sure that the staff and the practice is accountable to get them done. But you also need a physician champion. You need a physician, ideally, who will be the coding and documentation resource for ICD-10 within the practice, kind of a train-the-trainer idea. But if you are not a large enough practice and you can't accommodate that, even if it's outside the practice, so perhaps a hospital, maybe the hospital has a chief medical officer that has become an ICD-10 resource for medical practices that to see patients at the hospital, utilize those people. Or if there's someone in your specialty that you know has become trained and they can provide some assistance to you. But you need to have both a level of expertise appropriate to your specialty, but also a physician within the practice who will drive accountability from all the providers to get the training, to get the practice, and to get the processes in place on EMR templates and so forth, so that there's accountability to get things done, so that things happen as they need to before October 1 and then after October 1. Next slide. So this is the recommended gap analysis. So start with your top 20 codes, then go ahead and crosswalk those over to ICD-10. There are various tools for doing that. There's the GEMS tool, which we'll talk about in a few minutes. Make sure that, as I mentioned, any form that has ICD-9 code on it now gets accommodated to ICD-10. All your workflows, Superbill, practice management software, and so forth, as well as please make sure you contact your payers. And you may go with your top 5 or top 10, but identify who are your key payers and make sure you understand what is their transition plan and what's changing in their medical policies, ideally in their edits and so forth for ICD-10 so that you can plan around that. Next slide. Financial planning, the estimates vary. You can see different estimates. Here's from the American Medical Association that said, up to $226,000 could be the cost for a small practice. But look at for your practice. Do you use outside resources for staff or physician education? If you have your own hosted server for your software, is there any charge for the software update? Are you going to require any hardware upgrades? Are there any interfaces that need to be updated that you're going to be charged for? Do you need any electronic computer resources for coding and so forth? Staff overtime, forms, all the different things, as well as cash flow disruption. So what happens if your revenue is 10% lower in October and 20% lower in November? What does that do to your budget? Do you need to have a line of credit, or do you need to have cash reserves? The best practices that I've seen recommend at least 3 to 6 months either of cash reserves or cash access through a bank line of credit, just as a contingency plan in case there's a significant interruption in cash flow. These are the 3 levels of training, as we mentioned before. The key aspect is not only education, but make sure that for each of these levels of training, you identify and understand workflow impacts. And when I say workflow impacts, it's really trying to identify not only what are the forms and so forth that change, but where are the bottlenecks going to occur? Can we predict where, if there's going to be a bottleneck, where will it be? A certain activity with a certain person in a certain area, and how can we try to prevent that bottleneck from developing? Next slide. So for your coding education, one of the first places to start is your specialty society. So whatever specialty you're in, the first thing I would do is go to your specialty website, put in ICD-10 in their search box, and identify what are the programs and tools. Some of them have very good training programs, whether it's webinars or others. They have resources, but really identify what's most appropriate for your practice based on what your specialty provides first and foremost. Secondly, look at your hospital. A lot of hospitals are significantly, because they're impacted so much by ICD-10 as well, they're providing resources, either physician training resources or coder resources, but see what your hospital or your local hospitals provide that you would be able to tap into. CMS, the American Medical Association, American Health Information Management Association, and American Academy of Professional Coders all provide resources. All 4 of those actually provide webinars, specially oriented for physicians, so you can look those up and see which one's most appropriate for your specialty, or maybe take a couple of different ones. Even the office administrators have their own dedicated webinar. I think it's a 3-hour webinar on the AAPC website, so that's something you may consider. There's a cost associated with that, but again, it really provides a good education and overview of ICD-10 from a practice manager standpoint. What do you need to know and what do you need to plan for? You may want to have an outside consultant, so there's different consultancies that you can contact or you can Google. As I mentioned, I hope one of the take-homes from this is that everyone listening to this will get the top 50 ICD-9 codes from the AAPC. It only costs about $25, and I think it's an invaluable resource and a very good place to get started on looking at what are the impacts on your practice. And then look at what are the other tools, whether it's cheat sheets, standalone applications. We give a list of some of those, like the Precise tool, which can go on a smartphone, but what would make good sense for your practice. Next slide, please. So as I mentioned, make sure you have a physician champion. You're going to be at a significant disadvantage if you don't, because really peer-to-peer training and peer-to-peer feedback tends to work best with physicians. And so you want to make sure that everyone in your practice, from a provider standpoint, is doing what they need to in terms of training, that they're getting the feedback they need to become proficient in ICD-10. Using the computerized search tools, some of the options that we've mentioned, as well as make sure that you provide ongoing feedback to physicians. One of the things that I would recommend is you get your physicians educated as quickly as possible and then start walking through some case studies. So what are some of the most common encounters or the key revenue centers or key diagnoses for your practice? Do a couple of case studies, perhaps at lunch where the physicians would walk through that, or maybe stay after one day. Try to do that on a weekly basis where you're doing 1 or 2 case studies so that they can talk amongst themselves, learn from each other, and identify, okay, what's the best practice, what's the most appropriate ICD-10 code or codes for this type of a clinical presentation. Next slide. One of the key things to look at that I would advise as you're walking through your administrative processes is, in a sense, say, you know, I am a patient walking through the practice. Start with a new patient. What are the forms that they would be sent? What are the things that they need to do in terms of insurance eligibility and check-in? Because you really want to identify what are the forms and processes that are going to be touched by ICD-10 that need to be accommodated. Same thing on a clinical visit. What's going to happen to the patient? Who all is going to be involved in that service that's going to be tied in with the clinical documentation or providing a diagnosis? What checks and balances can we provide to make sure that our physicians and nurse practitioners and physician assistants are providing complete and accurate ICD-10 codes or the clinical documentation for a coder to select those codes? Patient checkout. Do we need to change anything related to referrals and prior authorizations, or at least for certain payers, so that we can prevent, you know, denials of prior authorizations and prevent the patient from having to come back and have issues that we're going to have to resolve and takes up time and effort? And also look at the back office things. So again, particularly payer contracts and payer contract monitoring, making sure you understand your billing information flow to MediGain, working with your client service manager on how things will come back, how we prevent bottlenecks. It's really a team effort, so make sure you work proactively with your MediGain client service manager to identify potential bottlenecks, risks, concerns, and try to prevent those for the ICD-10 transition. Next slide. Revising clinical processes, it's the same thing. So again, you can go down the list. I think we pretty much talked about all of these, but make sure that all of your clinical processes and any place where a service could become unbillable, that you identify those and try to ensure that you've got adequate documentation by the provider and checks and balances to catch those services so that they're not denied, or that you don't have labs coming back or labs calling you, asking for billable diagnoses. Next slide. From the trading partner standpoint, particularly on the payers, confirm that the key, trading partners, that's anybody that you're doing electronic transaction with, that they're ready. If you're calling up your payer, I would make sure that this is kind of the bullet checklist. What are the medical policies and procedures related to your specialty that are going to be updated or changed? How will you get those communications? Does anything change on prior authorizations or referrals? Are there any other claims edits related to your specialty that are going to change? Can you get accommodation on timely filing deadlines? Is there anything else that you need to be aware of from your practice to prevent denials and prevent payment delays from that payer? Also identify who's the key contact person. You can bet that there's going to be a lot of practices calling your payers after October 1. If you can identify the exact phone number or phone extension of the key resource, you'll be ahead of the game so that you can get directly to that person and get your problems addressed in a timely manner. And then also make sure that you're doing any ICD-10 testing, as we'll talk about in a couple of slides. Next slide. Make sure you update your software. So we've talked about that. Make sure that both the practice management and the EMR software are updated. Any coding scrubbers. For example, I know a lot of MediGain clients use Advanced MD. Advanced MD has a nice feature in there. There's actually an ICD-10 tracker. It's under the modules lab. So you can actually have it do a chart audit where it pulls the top 25 ICD-9 diagnoses. It can do a denials tracking report. It has coder and carrier analysis. So it has some nice features that you can use both before and after October 1 for planning for the transition, as well as accommodating the monitoring of the transition. Other systems, I know NextTech has ICD-10 functionality, as well as Interg and so forth. So work with your practice management or practice electronic medical record software vendor and identify what transition tools do they have and what resources do they have, and learn to become proficient in the functionality that they provide within your system. Next slide. GEMS, the key point here is general equivalency mappings are something that's provided by CMS. It's a way to really map a code from ICD-9 to ICD-10. A lot of the electronic medical record vendors are using this. The key point is that it's not the be-all, end-all, because only about 25% of the codes that map by GEMS from ICD-9 to ICD-10 are an exact match. So roughly 75% will result in an unspecified code. So oftentimes that will not be the code you want to use. You want to use a more specific code, because if you're using a lot of unspecified codes, you can expect that payers will probably be denying those or start denying those at some point. So get to the most specific code. that you can, but GEMS are a good mapping mechanism and a good starting place and tool that you can use, but just understand you cannot necessarily do a one-to-one take-home of the ICD-10 code that the GEMS provides, because oftentimes it's going to be an unspecified code. Next slide, please. So here's the internal and external testing. You can read through that. The point is, do the training, but then test after the training to make sure that the new processes are working, the new forms are working, that physicians have been educated, they are providing adequate clinical documentation. Do external testing if you have your own server or you're doing direct communication with payers, your electronic medical record and practice management software. And once again, on your MediGain billing workflows, work proactively with your MediGain client service team member. Next slide. Post-transition monitoring, the key point on the staff productivity is identify bottlenecks. Whether it's by functional area or by person, look for those bottlenecks and be prepared to try to address those and rectify those timely. Understand provider productivity. So if one particular provider is being slowed down, is it an education issue? Is it a process issue? Is it a resource issue? How can you get that bottleneck resolved? Denials, ideally you're going to want to look at those by payer, by provider, as well as CPT codes. So if you're seeing an outlier in terms of the number of denials, what education or what process changes do you need to put in place to fix those denials and prevent them? Ideally, you're looking at, or identify what's your monthly revenue on average by payer preceding October 1. So what's your average monthly revenue for Anthem, Medicaid, Medicare, and so forth, and then look at it post-transition. If you're seeing a significant decrease in your revenue, is it due to one particular payer? And then you can look to work proactively on identifying what's the reason within that payer. Is it at the payer, or is it because of higher level of denials of things that your practice isn't doing or medical policy changes? But then you can identify the problem. And that's where, again, that payer correspondence really becomes important. MediGain planning, so we're testing the clearinghouses that we use for each of our practices depending on your software. All of the hosted practice management and EMR software we're doing the testing on. We're educating our coders. We're planning workarounds for the impacts on our coder productivity, as well as planning for denials and underpayments. But once again, it's a team effort, so we need you to communicate payer information to us to help prevent denials and rectify denials as timely as possible. We're working to assist clients, and that's what our client services team is waiting and able to do. And a key point is for clients who don't code their own services, you must ensure that you provide adequate clinical documentation for the MediGain coders to code appropriately. If not, it'll have to be sent back to you. For the MediGain clients who do code your services, you need to ensure that you have complete and accurate ICD-10 codes submitted to MediGain, because we're not going to be checking those codes, and so it'll be the payer that rejects it, and then you're going to need to work with us on the denial side. Next slide. So this is the list that I would recommend as an action plan. Identify who it's assigned to, what the deadline is. Make sure that you have post-monitoring and feedback, so your job is not done October 1. You really need to have proactive monitoring and feedback. Next slide. So the summary, take action. I know it's painful. I know there's a lot to do, but it's important that you get started now. Break it into specific problem areas or tasks, and that's what we've tried to provide a framework for doing in this presentation. What are your key risks? Actively manage them. Make sure you have a process to provide aggressive education, as well as monitoring and feedback to both your staff and providers. Make sure you proactively contact your payers, look for changes, identify risks and updates you need to do, and then make sure that you have a plan for the post-transition monitoring so that you're following what are the problems, what are the denials, and then you're providing feedback both to MediGain as well as to your providers on how to prevent those denials. I think the next slide is our resource slide. So this is the list of resources. So just quickly, the first one is a list that from a health system that I thought had some good specialty-specific pointers and webinars, so you might want to look at that. We've given some applications that may be good for your smartphone. I think several of us like the Precise application. Road to 10 is from CMS, and so they have specialty-specific webcasts, ICD-10 basics, and action plans, and then you can read down through the list. So these are good places to start. You can find other ones as well. So with that, I'll turn it back to Clint, and we can go ahead and take some questions.
Thank you very much, Eric. You have a questions box there on the right, ladies and gentlemen, so go ahead and put in your questions. I'm going to ask Carl to speak from the client services side of the fence about ICD-10. What would you like to tell our clients?
Thanks, Clint. I just wanted to first off thank Dr. Beyer for a good presentation. There's a lot of information in there. This was meant to be a high-level overview and kind of a starting point. There is a lot of work left to do. So I think that my recommendations have been a couple things. One is take advantage of local training. Every hospital that I know of is providing ICD-10 training. They're in the same boat we are. If the doctors don't provide good documentation for the services rendered at the hospital, the reasons for the admission and procedures that were done, then the hospital is not going to get paid. So they have a very vested interest in ICD-10 training. Second thing I tell folks is to think of this as studying for an open book test. It's really not about trying to memorize 60,000 ICD-10 codes. It's really about trying to understand how to access the information that's there to support you. And then obviously you want to look at the workflows and what you're doing in the practice to make sure that the doctors are ready. Those are my recommendations, Clint.
Okay. Elizabeth, could you speak a little bit, because you are the head of our coding department, so what would you like to convey to our clients?
The major thing that we need to be concerned about is documentation, because like Carl was saying, it's going to be a more specific diagnosis, and the concern is that once the payers start receiving these, they may start denying based on diagnosis. So it's really a good idea to go ahead and take advantage of all the training that's going on right now for the ICD-10 and get your documentation as accurate and complex and specific as possible.
So yeah, that's just remember the 2 Ds. It's diagnosis and documentation. And we here at MediGain, we can't diagnose your client for you, and we can't document what you're doing to them. So those are the first steps, and we gave you all these resources that you can look at. And be on the lookout for an email coming from me later on this afternoon. It will have a link to our website where you'll be able to see the video. You'll also be able to download the slides. And in the body of the email, I will put all these links live so it's easy for you to click onto. Let me check for questions one more time from out in the field there. Okay, any parting words, Dr. Beyer?
Well, I think the key point is it's easy to be overwhelmed. There's a lot to do, and if you haven't been doing anything now, don't throw up your arms in the air and say, it can't be done. You just need to do it in breaking the problem down into pieces. Use the framework that we gave you, start the education, use some of the key tools and resources, and do it a step at a time. And I think you'll get there. So again, the key point is call to action. Make sure you get moving now if you have not started it, and MediGain will be there as part of the team to help you out through this.
And Carl, all our client services people will have copies of these slides and resources, correct?
Absolutely. So if anybody out there needs them, don't hesitate to get a copy from your account manager, to share them with your friends and neighbors and other doctors in the practice. It is good information. It's not too late to take action, and really encourage everybody to be ready for October 1st. Thank you, Clint.
You bet. And thank you, Dr. Beyer. Thank you, Carl. And thank you, Elizabeth. If you don't get the email that gives you the link, press the button to go here to download, email me at marketing@medigain.com. Check with your client services people, and we'll be in touch with you. We're here to help you through this as best we can. So let everybody know that tomorrow at the same times, the first one is at 11 a.m. Central, noon Eastern, and then the other is at 11 a.m. Pacific, noon Mountain, where we'll be going into a little bit more on coding. And so any of your physicians that weren't able to be on today, have them tune in tomorrow. And please do share this with all your physicians and all your staff within your organizations. And we'll have more webinars coming up. Once again, thank you for tuning in. Thank you, Dr. Beyer. Thank you, Carl. Thank you, Elizabeth. And thank you all for being MediGain clients. We'll see you soon. Bye-bye.